I want to thank you all for being here. This is our Strangulation for Advocates training. We try and do this training at least once a year. We try and host it in October in recognition of Domestic Violence Awareness Month. I'm Natalie Olias. I work with the Family Justice Center, and the Family Justice Center coordinates a Family Justice Institute.
On here too.
And it's
The housing investigator for here.
Oh, if you could go ahead and mute yourself just in case you haven't done that yet, that would be great. And please feel free as we're going through to put questions in the chat box. So I'm just waiting for one more of our presenters to come on. I apologize for some of the inconsistent Zoom links that are out there. I realized that there were two, so I sincerely apologize for that. Ashley, do you want to go ahead and introduce yourself while we're waiting for Carrie?
Sure, yeah. Hello, everyone. I am Ashley Palomino. I am the Intervention Support Services Manager over at STAN. So I oversee the 24-hour hotline and our community advocates out in the community. I also oversee the lethality assessment program we have at STAND in partnership with several different law enforcement jurisdictions in Contra Costa County. And I'm also a part of the Strangulation Task Force.
Thanks, Ashley. And I think Carrie just joined us. Carrie, are you on?
Yes, good afternoon.
Hi there.
Hello.
I'm so sorry about the Zoom link issue. I apologize.
Not a problem. We figured it out.
Great. Let me go ahead and pull up the slides and we'll get going.
Perfect.
All right, Carrie, it's all yours.
Fantastic. Well, thank you so much for having me today. It's really an honor to be able to talk about a hard subject. I'll go ahead and introduce myself. I'm Carrie Watson. I'm an OBGYN physician with Kaiser Permanente here in Northern California. I work in Contra Costa County at the Antioch Medical Center. And I've given this talk a few times. I think it's really a critical topic to really understand the risks that our clients or patients may be facing when strangulation is involved in their abuse. This is probably a great moment just to acknowledge this is a pretty heavy topic. So I usually like to start with just, a couple deep breaths to sort of ground yourself, center yourself, and remind you that this can be kind of triggering or just heavy. So if you find that it's a little bit too much, it's always nice to just look away, put 2 feet on the ground, even stand up if you are able and kind of walk around your room. Sometimes that can just help you kind of reestablish feeling centered in yourself, or even turn off the sound if it's just a little too much. So I do have a section with photos, but I will give a very clear trigger warning. And of course, people can choose whether or not to participate in that section as well. So big deep breath together. And then let it out. It's Friday. And then we'll take another big deep breath. All right, we can go ahead. So most of the information that we have learned about strangulation and its risk in domestic violence, but also the medical risk of strangulation, it all started in 1995 in San Diego when these 2 young women, young mothers, were murdered by their partners. And what the district attorney at the time noticed was that both of them had been strangled really kind of right before they were murdered. And it was the first time she sort of had an aha and said, gosh, I wonder if strangulation is somehow a marker for homicide. And if we had known about, the risks of strangulation, would we potentially have been able to intervene and save these women and make a different impact in their families? So that's Cassandra Stewart and Tamara Smith. We can go ahead to the next slide here. So all the information I'm presenting to you, or at least the majority of it, really comes straight from the Institute of Strangulation Prevention. This is part of Alliance for Hope down in San Diego. And you can find the information as well as some of these images through the website, which is listed here. So the first thing to know is just what is strangulation? You know, a lot of times a client will say, you know, that their partner choked them. But what they actually mean is not choking. Choking is when food gets stuck in the windpipe instead of the esophagus, and then it's hard to breathe because there's actually an obstruction inside the trachea, the tube that we're used to breathe. So that's actual choking. Strangulation is when there's pressure applied to the neck. We can go ahead to the next slide, Natalie. When pressure is applied to the neck, it usually happens with hands, but it can happen with other devices, such as like a belt or a rope, or sometimes you can see this with law enforcement, right? George Floyd had this situation as well with a knee to the neck or a knee to the back. And as I mentioned, you know, clients and patients, they don't always use our language. So they may say things like, my partner choked me, or I was strangled or suffocated, or I couldn't breathe, or, you know, or they may just say physically what happened. I've had patients say that, like, oh, he put his hand on my neck and then I couldn't breathe. Next slide. So this is a medical diagram of the structures inside of the neck. Please do not allow it to intimidate you if you're not familiar. On the right side, you'll notice that there are these big tubes, right? This big blue tube, big red tube. Those are the blood vessels. The red one, the artery taking oxygenated blood to the brain, and then the blue one, the vein taking deoxygenated blood away from the brain. And that's really what happens in strangulation, is that these two tubes, they get compressed, right? So if you can picture a hand kind of covering over those tubes, the vein is sort of the first one to get compressed. And then if the pressure, you know, is stronger or prolonged, then the artery can get compressed as well. And what happens when the blood flow is blocked is that oxygen can't get to the brain, right? And so this can lead pretty quickly to loss of consciousness. Even if the pressure is not that strong initially, when the muscles aren't getting adequate oxygen, they become really what we call flaccid, or they become weak, and it allows that pressure to push more internally into the neck and obstruct the carotid artery as well. There's these little like nodes in there with the nerves. They're hard to see in this picture, but that's like the carotid sinus, and when those get stimulated, it will cause automatic reaction, which means the heart rate goes down. That's bradycardia. And then also the blood vessels are trying to dilate. This is to try and attempt to get oxygen up, even when it's not possible because of the obstruction. So that's what's actually happening in strangulation. Next slide. So the effects of this can be fatal, and that can happen really quickly. Loss of consciousness can happen as quickly as 10 or 20 seconds. And this does depend a little bit on how much pressure is being applied, and also whether the pressure is continuous or intermittent. So when there's a lot of pressure and it's continuous, you'll see these negative outcomes happen more quickly. If the pressure is lighter or is intermittent, sort of coming and going, then it may take longer to see some of these negative effects, right? So with a lot of pressure that's continuous, you can see loss of consciousness very quickly, just in a matter of seconds. Brain damage can happen in 3 or more minutes. Death can happen very quickly as well. Doesn't take long, you know, when the brain's deprived of oxygen to cause death. There are a lot of risk factors that can sort of help us predict when strangulation may be present. Most women who experience strangulation, and I use women acknowledging that strangulation can happen to anyone of any gender identity, also in any kind of relationship. I will say that the majority of the data we have is gendered. It shows a gendered, that this is sort of a gendered activity, and tends to happen, although not exclusively, but tends to happen in relationships with a female victim and a male partner. And that's where most of the original data came from. So you'll see that gender acknowledgement here in some of the slides. Most of the time when people are strangled, it's not the beginning of abuse. It's often happening with a past of abuse. that's sort of escalating, and strangulation tends to be a marker of escalating violence. It's also often accompanied by threats of more harm and even death. Many people who experience strangulation, and this is true of a lot of settings when people are starved for oxygen, but there's a great fear or a great feeling that death is imminent. People who use strangulation often have a criminal history. We've talked about how it can be fatal, and like many forms of abuse, even though this is quite violent, a lot of time kids are just right there watching this. And of course, witnessing domestic violence is an adverse childhood experience that can really impact the health and well-being of children much later in life. Next slide. Strangulation also is a predictor for both attempted homicide as well as completed homicide. And this was from a review of, I want to say, about 300 homicide victims where they were able to notice strangulation and the link with homicide. So it's something we take very seriously. What is fascinating about such a high risk, very violent act is that much of the time there's no visible injury at all. And I think this is probably one of the biggest reasons that historically strangulation did not get a lot of attention. About half the time, someone could experience this, life-threatening, very serious event and actually have no marks. There's a group, the blue group underneath that is about 30% or so. And those are folks who will have visible injuries, but they're so faint, you can't even photograph them. And then that bottom group, I think it's less than 10% actually have visible injuries that you could actually document in a photograph. Next slide. So that makes it difficult. It means we have to ask about it, or we may not know that it's happening. And sometimes patients won't remember, or I say patients because that's sort of my context, but you know what I mean, our clients. They may not remember what happened because they may have had some loss of consciousness or may have suffered some impact to their brain or memory. So sometimes if we ask about strangulation and we get a no, that it didn't happen, we can ask about some of the symptoms. So strangulation is often accompanied by experiences of throat pain, sometimes voice changes. After the fact, clients may have breathing changes or difficulty. They may have difficulty swallowing. As I mentioned, they may have loss of consciousness, and this can be associated with seizure-like activity or twitching. They may have pain in the ears or headache. They may be hyperventilating to try to recapture some of that oxygen. And then sometimes when there's loss of consciousness, there can also be loss of control of the bowel or the bladder. So, and sometimes clients will try to hide this. It's embarrassing, but they may have urinated on themselves or defecated on themselves, or you can even ask, hey, did you change your clothes? And a client may say, oh, I did. Oh, you know what? My clothes were wet, right? That's very helpful to kind of understand what happened. And then kind of like, the visible injuries are not always there. Patients may have no symptoms after experiencing strangulation. On physical exam, as I mentioned, this can be really difficult to see based on just what we see on the patient in front of us. If we do see something, you may see cuts, you may see bruising or finger-shaped imprints, particularly on the neck, on the sides of the neck. Bruising can also happen under the jaw, behind the ears. Sometimes you'll see, and you can see this sometimes with other kinds of injuries, but in this one, you may see like thumbprint bruising, or you may see usually it's just 3 lines in a row because the pinky doesn't have as much weight, and so it doesn't tend to put as much pressure and cause a bruise, but you may see sort of 3 lines in a row representing fingers. You also may see scratch marks, and sometimes these are self-inflicted. You can imagine a client trying to remove the assailant's hands from their neck, and in the process scratching themselves. So they may be self-inflicted. And then, as you mentioned, many of these injuries might be too subtle to even document with a photograph. The other thing that's important to watch for, and this can have other causes aside from strangulation, for instance, prolonged vomiting can cause this, but we call them petechiae. They're little tiny red dots that you might see in the white part of the eye, or you could see if you looked inside the mouth on the upper part of the mouth, we call it palate. Sometimes they're present on the skin, but they're a little harder to notice. So these can happen in strangulation. They can also happen if some other things like vomiting were happening as well. Next slide. And then sometimes, if the patient survives the experience, there can be some other serious outcomes aside from, the near fatality or the fatality. There's a rare risk, 1 to 2% of something we call carotid dissection. And that means that the carotid artery, which again takes oxygenated blood from the heart to the brain, would actually essentially sort of like develop a tear and start having either bleeding within the layers of the artery or cause bleeding into the neck. And if it doesn't sound scary, it should. That's a pretty serious event that can lead to stroke or even death on its own. It's also possible to have injuries to the spine related to strangulation. Stroke is also possible, and then of course, traumatic brain injury. Next slide. So this is looking at a study of about 400 exams on people who were strangled, and they found a rate of about 5% for adverse medical outcomes. And they included some of the ones we talked about, that carotid artery dissection, although they had a lower incidence. It was only about 0.5% of all cases. Two situations have what they call a hyoid bone fracture. There's a little tiny bone in the neck right here called the hyoid bone. It used to be thought that if someone was strangled, the hyoid bone was always fractured. But actually what we've learned is that that's not true. It's typically not fractured, but it can be. And that can cause, of course, pain. And it's dangerous to have, bony fragments in the neck because there's so many fragile structures there. Also, we see a lot of swelling. Sometimes it can be quite severe, inside the neck. That can make it hard to eat, swallow, breathe, things like that. Herniated discs, of course, in the spine, and then several other, sort of a variety of other outcomes, including miscarriage, stroke symptoms, or what we call a transient ischemic attack. It's essentially a stroke that is not permanent. Enlarged lymph nodes, pleural effusion means a lot of fluid in the lungs, other fractures, and other negative outcomes with the carotid artery. This is a medical kind of algorithm. If you see X, then do Y, which the Institute for Strangulation Prevention has created with the help of some of their medical experts. We use this at Kaiser Permanente, and we've included it in our links for management of domestic violence and other sorts of assault. And this is really helpful. We've tried to share this across the county so that all of our emergency departments have this so that they can sort of help figure out what to do in terms of further evaluation for people who've experienced strangulation as well as management. And so really this kind of subdivides between what symptoms are present. When there's no symptoms, that's sort of to the right, then, after evaluation with a medical professional, they can kind of have strict precautions and head home. But if there's any of the symptoms on the left, loss of consciousness, visual changes, incontinence, neurologic symptoms, difficulty speaking, or breathing, then it's typically recommended to have further evaluation with imaging, and that's often a CT. And then sometimes they recommend monitoring for a little bit longer because it can take some time for some of the swelling to set in, right? If you've ever, run into something that you knew was going to cause a bruise, often you don't see it right away, right? The swelling sort of takes a few hours to really develop. So the same thing can happen in this scenario, and sometimes prolonged monitoring can be beneficial. Next slide. Yes, so this is why many experts recommend continued observation, particularly for folks on the left side of that page we were just looking at, for up to 12 to 24 hours, particularly when these other things are present: loss of consciousness, petechiae, soft tissue injury, incontinence, or, we know that going home just really isn't very safe. So those are all settings where further evaluation might be helpful. So this is a case study shared with us through the Institute of a 22-year-old who came in with neck bruising and pain. Initially denied any sort of abuse or strangulation, but had some more obvious signs of this on exam: bruising, tenderness, pain on movement of the neck. The physician was concerned about possible strangulation and did a further evaluation, at which point the patient did admit to being assaulted and strangled. The police were already involved. She did have a CT angiogram that showed a left carotid artery dissection, and she was able to start, it sounds like a minor treatment, giving aspirin, but actually this is life-saving. It thins the blood just enough to prevent clotting. The risk in this situation is clotting that could then sort of break free and go to the head, go to the brain and cause a stroke. So the patient was started on aspirin. And then, despite efforts for additional services, didn't want any. Next slide. This is an image actually of a different patient, but it does demonstrate sort of what these carotid artery dissections look like. You may not be familiar with viewing CT images, but this is sort of a slice, if you're imagining the head kind of like from top to bottom. And the bright white structures are bones, and then those sort of medium white structures that the arrows are pointing to, those are the carotid arteries. But you can see the point where the arrow is looking, there's a real narrowing on both sides. So this is a patient who was very lucky to have been evaluated, because it's possible to have an obstruction on both sides and then really not have any oxygen going to the brain. So she was able to have life-saving treatment as well.
And Carrie, just in the notes, it specifically says 6 days after her assault. So if a client comes in and it's been several days, should they still go to the hospital?
This is a hard question to answer, Natalie. There's not definitive data about this, but you're right. This patient was 6 days later. It seems like a long time.
Yeah.
I think it's worth asking about what the symptoms were when the assault occurred and in that first 12 to 24 hours. And if they had some of those symptoms along the left side of that algorithm, then yes, I would refer them for medical attention. Now, if it was 2 weeks, if it was a month, if it was 6 weeks, the experts don't agree on sort of the length of time for which someone should have medical evaluation. Definitely, I would say in the setting of persistent symptoms, yes.
Okay.
Or if the symptoms seemed quite severe at the time of the assault, it could be considered. But in terms of like emergent evaluation in the ED, definitely within a week, maybe 2. This is where there's a little more art than science, right?
Great. Thank you.
So we're going to show some images, really just as an aid to you, so that if you're with a client and you notice some of these bruises or other sorts of signs of injury, that you'll possibly probe a little deeper. Some of these images can be triggering. So I invite you to sort of practice some self-care and decide if you'd like to participate in this section. I know Natalie is going to be sharing those images later, so you could also choose to view them that way. Also, the images are available through the Institute on Strangulation Prevention website. Let's go ahead to the next one. So this is an abrasion kind of right underneath the chin. And this is sort of interesting. We don't think of our chin being able to touch our neck, but when we're really trying to get away from someone, it can, and it can cause a bruise, right? So this is someone who put their chin all the way down, sort of in a really fast way, enough to even cause a bruise kind of on that part of the chin. So you might see something like that. These are scratches, right? Excoriations that may be self-inflicted. This is kind of that thumbprint bruising right behind the ear. You know, both this and the last picture, there's really no reason that you would see something like that. Or it's hard to imagine a story that's not strangulation when this might happen, unless, you know, for instance, this patient had like a direct blunt trauma from something else. Again, thumbprint bruising on the neck. Apologize, I know this is a little grainy for this photo. And then this is a little more subtle. So you can see these kind of brighter red marks sort of towards the right side of the screen. But then behind them, you can sort of see at least two sort of lighter lines. And that really suggests like probably at least 3 fingers on this side. So you could imagine either something similar on the right side of her neck, which we can't see, with a perpetrator using 2 hands, or it's also possible you might see a thumbprint on the other side with the perpetrator sort of grabbing the neck with one hand. And then here's a list of some additional sources. The website is also listed here below for additional information. What questions does everyone have?
I'll stop sharing for a minute here. Any questions for Dr. Watson? Okay, it's a quiet group today.
Well, thank you so much for having me. I'm actually going to drop off for another meeting, but just so appreciate the invitation. Thank you.
Absolutely. Thanks, Dr. Watson, for being here. All right, we're going to go ahead and keep going. So this part of the training is really going to focus on protocols that have been put into action in Contra Costa County. That being said, there's statewide mandates for these protocols. So this is how Contra Costa responded to those state mandates. And obviously, if you're working within another county, you might have something very similar, and or you're still trying to put in place something along the lines that Contra Costa has. So please feel free to, you know, after the training, if it's something you're still interested in, you can always ask myself or Ashley, because we've been heavily involved in this work now for several years. So let me go ahead and share my screen again. So again, talking about the strangulation response in Contra Costa County. So there's a lot of different folks on this call today. A lot of you are advocates. Some of you are advocates for domestic violence survivors. Some of you are advocates for sexual assault or human trafficking survivors. Some of you are advocates with DA's offices. And so when we usually talk about strangulation, it's in the context of within a domestic violence relationship. That being said, we have seen situations where human trafficking survivors have been strangled by their exploiters. We have seen other cases where, you know, a parent might strangle a child. So there's a lot of different scenarios that play into how a client can come in and try and get services. And these are important markers for you all to be aware of. So in talking about the legislation, so in 2018, all prior to COVID, California passed something called SB 40. And what it required is it required law enforcement responding to a domestic violence incident if there was any type of choking, strangulation, blockage of airway mentioned, that law enforcement is now required to not only give the victim a verbal warning, but also give them a piece of paper with that warning on it. So that's statewide. Every county in California is supposed to have that now. Law enforcement is required to do that. For those of you that are in Contra Costa County, as you are aware, Contra Costa has 26 law enforcement agencies. And so getting them to do anything in a uniform way is really difficult. And so in the beginning of 2019, we created a strangulation task force. And there's several partners involved in that. There's the Family Justice Center, Stand for Families Free of Violence, which is our domestic violence crisis center for the county, several county offices, police departments, and also healthcare providers as well, and the district attorney's office. And the goal was to try and do a couple different things, but it's really focused on how are we going to implement SB 40, because not only does it impact law enforcement, but if law enforcement gives something to a victim that then a victim goes to a domestic violence crisis center with and says, here, I was given this, we need that advocate to know what that looks like, right? We need to know what that piece of paper is saying and have a protocol on how to handle that. Similarly, since we're talking about strangulation, there are going to be times where a victim's going to go directly to a hospital. And if they give a hospital, say, this is what the police gave me, and that hospital doesn't know what that paperwork is, that's not going to be helpful either. And so the task force really created a way in which uniformly, as much as possible, at least within Contra Costa County, everybody could recognize, okay, this is the protocol that we need to work on. This is what we need to follow. And so one of the things that the task force did was created an advisement card that law enforcement now carry with them. Again, all 26 law enforcement agencies, their chiefs signed off on this, so they should be utilizing it. And the main thing here is to note that it has the quote that law enforcement has to verbally say to somebody. And then it also has the signs and symptoms to look for, like Dr. Watson was saying earlier. You know, is their voice scratchy? Are they having trouble swallowing? Have they not been able to eat anything because they've been having trouble swallowing? Any behavioral changes, being very foggy in memory. These are all signs that somebody has a serious medical issue and needs to get looked at. And I'm going to pull up the specific language that was put into this document. So the main thing that we want victims to be able to hear is that research shows if you have been strangled even one time, you are 750 times more likely to be killed by your partner. And this statement causes alarm, right? When you see that, that's alarming. And that's on purpose. This language was taken from the Strangulation Training Institute for the purpose of remembering, having a victim remember that piece of information. On the other side of the card is where health advocates come in. So if somebody goes into the emergency room with this card, on the back of it, it actually lines out the type of scans the victim really needs to get. And of course, we have the incident number and everything. So if they need to contact the police, the emergency room needs to get a hold of the police. They know who to reach out to because they know who the victim is working for. But this really helps narrow down, okay, we know this is somebody that has been strangled. We need to do X, Y, and Z. And the protocol that was created, Ashley's going to talk a little bit about Stan's protocol as well, but the Family Justice Center protocol that we implemented was if a client comes in and starts talking to us, and then a situation that I've had before is somebody has a really hard time swallowing and has a really scratchy voice, and she had a little bit of fogginess to her. She had been strangled a few days prior. It was like in that 4 to 5 day window. So that's, as Dr. Watson was saying, it starts to get a little iffy in how far out you go when an incident happens. So the first thing we try and do is assess, okay, when did the strangulation occur? When did this happen? And then assess if she needs to go to the hospital, if we need to stop what we're doing at the Family Justice Center right now and focus on getting her support at the hospital to get evaluated. And again, the reason for that is because of all the risks that we just learned about. Also explaining the severity of strangulation to the client. As Dr. Watson mentioned, if you're being strangled and you lose consciousness, you don't remember what has happened, right? You're only going to remember waking up again and either being on the floor or something, you're being in a different position, but you're not going to remember what actually happened to you. And so a lot of times, especially with domestic violence survivors, they can minimize what has happened to them. And so it's really important to relay how risky and dangerous it is to be strangled. And in our protocol, we want to connect. If somebody's not interested in medical, we've told them the risks. We've said, you know, you really should go get checked out. They don't want to do that. We're going to respect that. What we're still going to do is give them that advisement card, because we have copies of it as well, so that if they do end up deciding to go later to the hospital, they still can. But we're also going to connect that victim to STAND right away, because we want to do an evaluation of that victim and get them connected with an advocate who can provide them services. Ashley, do you want to jump in and talk a little bit about STAND's protocol when a client calls in and says, you know, has those markers and everything?
Yeah, absolutely. Yeah. So in STAND, we get calls in a variety of different ways, not only from our partners, but also from our 24-hour hotline, or they walk into our sites from within the community. And the Strangulation Task Force has been super helpful, and all these trainings have been actually really helpful for us as advocates, because we didn't always have this information. And it's really hard to kind of get those details from victims who don't remember what happened, right? When they're telling you their stories, you're sitting down with them, they'll talk about an argument and then they don't really remember. And then they remember being on the floor in this position. That is a sign that they probably were choked. And until we started actually learning this and assessing this, that's when we were able to identify those as signs. And we're able to get that not only in our conversations and assessing, trying to figure out, piecing together the timeline of the incidents, the relationship history, all of those pieces, but also in our lethality assessment protocol, we ask the question. We also try to mimic the language of the survivors, right? Because if you ask a client, have you ever been strangled? They will tell you no, but I've been choked. Or maybe they had their hand around my throat, right? Their language is super crucial because they don't necessarily understand all that medical dialogue, and it's for us to be those translators, right? And so we're able to give them the information and translate choking into strangulation and those risks. So when we do hear that a victim either doesn't remember, or sometimes they tell us they got so scared during an incident they wet themselves, is actually a sign that they were likely choked during that incident and just don't remember. We really safety plan with them and figure out what are the next pieces. We talk to them about our partners at the medical facilities too, to get checked out. I know that there was a comment about wanting to see pictures of darker skinned folks. We don't have them because you can't see that. What you can see though is those scans. And that's why the scans are super crucial, because again, a very small percentage of folks who have been strangled will have any visible marks, period. However, they are at a huge risk of dying even after the incident because of blood clots, right? So even if you feel fine and it's been a few days, we still encourage them to go get checked out and do those scans because of the risk of a blood clot, because you may not know that you have a tear, right? You may not have anything noticeable. And it's for us to relay that to them and let them know that we can help you, direct you, give you the right information. And now the medical field will be able to respond in that way, because now they have also been informed about this protocol and it's been in effect for a while, right? And so they are able to believe survivors around the incident and do the next steps to assess in the right way to make sure that they are safe, because it can be hard of even in the court system, sometimes not having any visible marks has been shown to not happen, right? And make the victim not believable, but it does happen, right? And there are very minimal instances where there are bruising, marks, scratches, etc. So it's really about us supporting the survivor and understanding the risks, safety planning with them, and then linking them to the appropriate resources, whether that's coming into shelter, whether that's restraining orders, whether that's the police, etc., whatever step they're ready to take to increase their safety. So going back a little bit to our lethality assessment program, for those that don't know, the lethality assessment protocol is a research-based initiative from Maryland Network Against Domestic Violence. This is a tool that was based off of Jackie Campbell's danger assessment, and it was compared against domestic violence homicides within Maryland. And they were trying to assess, is domestic violence homicide preventable or predictable? They were able to find 11 key questions that were present in all of the domestic violence incidents of homicide. What they found is that only 4% of those victims who had been killed by their partner had any contact with the domestic violence agency in the year before they were killed by their partner. However, about 50% had some interaction with police at some point within the year prior. So it was a huge gap between the highest risk of those being killed, seeking domestic violence services versus having some interaction. So the goal was to bridge that gap between law enforcement jurisdictions and the domestic violence agency. When this was initiated in Maryland, it was shown to decrease the homicide rate by about 50%. STAND has initiated this protocol since about 2015 as a research pilot project. We started with Yale evaluating the research and local evaluation with University of SF. And we have kind of sustained the project. We only partner with 4 out of our 26 law enforcement jurisdictions right now. And what that means is on the scene with domestic violence victims, officers complete a screening and then call in those that are at the highest risk of being killed by their partner into the hotline and are immediately entered into services. We still respect victims who do not want to enter service and try to follow up with them and safety plan with them even after the incident. But the goal is to say very explicitly, just like with the strangulation piece, that you are at risk of being killed by your partner. One of the questions on the left is about choking. Have you ever been choked by your partner? So in addition to officers initiating this on the scene and calling into our hotline, all of our advocates, both in the community and on the hotline, do initiate this screening as well with folks who are calling in for services or to talk, using it as a learning tool, an assessment tool, trying to assess where they're at and then how can we safety plan with them as well. So when we start to hear some of those risk factors, particularly around potential strangulation or not remembering certain things, we really want to initiate this tool to again assess what is their risk of being killed. Because as we know, strangulation and domestic violence in particular is a huge risk factor for homicide. We want to assess that and give them not only the information and safety planning, but also let them know of their risk, because sometimes people don't really recognize. The one interesting thing about strangulation is there's a lot of misconceptions about how strong you have to squeeze someone's throat, and it's a lot less than people would think. Really, if you think of a firm handshake, that's enough to cause some significant damage, and enough to make someone either lose consciousness or die by a simple, firm handshake. So it does not take very much pressure to start cutting off the blood vessels, taking the bad blood, if you will, from the brain to the heart to get the oxygen and vice versa. So it's very minimal, and people don't realize even just a slight pressure on their neck is very dangerous. So again, we use this information to kind of educate them a little bit and also hopefully help make those connections to the medical offices within our county.
And I know folks, you're not going to be able to read this very clearly, but this is what the lethality screen looks like. And let me go to the next slide. So Ashley, do you want to talk a little bit more about question number 5, if somebody answers yes to that?
Yeah, so the lethality assessment is scored in a couple different ways. So there's one way that is an automatic, and so you have to answer enough yes questions in order to be high danger. However, anyone initiating screen can screen them in as a belief, whether or not there's enough yes answers. And so again, number 5 question is, have you ever been choked? Right? So it's choking, not strangulation, because again, victims, survivors, they do not recognize strangulation as strangulation. That's something totally different. They often think of like with the ropes or with belts or things like that around their neck, not manual strangulation, which they consider that to be choking. So again, it's about using the language of the folks we serve in order to have them understand and us to understand what's going on. And again, shift that language from choking to understand that it was actually strangulation that they're referring to. They're not choking on items, they're being choked, right, with a hand around their throat or other means. So again, once we hear a yes to that, that initiates the information we give to health services, to our liaisons and the advocate, to shelter potentially, right, other resources to help them remove themselves from that situation if they're still in that situation, if they're ready to take those steps, and really safety plan with them around those high risk factors, because they are at risk of being killed, and the likelihood of them being killed is significantly high. What we also find in domestic violence is when someone has began to choke or strangle their partner, they are basically saying, I will do anything, and I have your life in my hands, right? And so it is the full sense of power and control. And it gets a lot harder, as we know, to leave relationships because of that power and control dynamic. And so it is even more dangerous, and it will increase the dangerousness in the relationship. So again, it's really letting them know about how dangerous it is, not only being in the situation, but also medically too, and the after effects of that. We also have the options of working with a multidisciplinary team within Contra Costa County. And so that's a group of folks on the Strangulation Task Force, a lot of other agencies too, where we talk about cases, nominate cases, kind of wrap around the family to, again, prevent this case from being a potential homicide. So it's high risk cases that we want to work with and support with either legal assistance, housing, a variety of other resources too, to make sure that the family is safe. And then, like I said, encouraging them into services, whatever services they are ready for at that time. Again, understanding that sometimes they are not ready and do not want services, but at least we know that we're giving them the information so they can kind of digest and take the steps as they need. So again, because we have the lethality assessment program since 2015, overall, I've been able to pull some data to show that about 60% of the victims who had a screening to the lethality assessment screening from law enforcement and advocates was about 60%. So 60% of the folks, more than half, said yes, they were choked by their partner, which is pretty significant, right? Again, as you can see, there's a little bit of decline from 2020 and 2021. Part of that is because of COVID. Calls did drop a little bit. Partners also shifted in the lethality assessment program. So things shifted between 2020 and 2021. But as you can see, kind of as a starting to peak up. Overall, it was 60% that have said yes, they have been choked. So it is a significant factor within the domestic violence relationships that we are seeing in our county of Contra Costa County. And this again includes not just the advocate initiated ones at STAN, but also the law enforcement jurisdictions. So STAN initiates the lethality assessments for anyone who calls in, regardless of the jurisdiction that they're within. So it could be anyone outside of the 4 law enforcement jurisdictions we're currently serving.
Thank you. And I think our last slide just has our contact information. But I did want to pause and just, since there are mostly advocates on the training today, to just get a sense of if you all have questions, if you all have been able to establish, something like a strangulation task force or anything like that, if there's any questions that you might have around that. I think the main thing is for folks that don't necessarily deal with domestic violence as frequently, but see other types of violent crimes and work with those victims, the main thing is you can always connect them to the Family Justice Center. You can always connect them to law enforcement if they need to be. You connect them to the hospital. You can connect them to STAN too, because at least we all have the strangulation protocol under control. We know what it is. We've done trainings with Kaiser is on top of it. John Muir all of their doctors are getting trained, especially their emergency room physicians. Sutter Delta is getting trained as well. So really we wanted to cover any area emergency room to be able to recognize those cards and understand the severity of strangulation. We even had a situation last year where a woman, monolingual Spanish speaker, had been strangled by her partner the night before, had finally been able to get away, got access to her phone, was scared to go to the emergency room, but you could tell her voice was raspy. We needed to get her set up we got STAN involved. We were able to also get her connected through a telecare program that STAN and Family Justice Center are a part of. We were able to get alert the emergency room that she was going to be coming in And because she's a monolingual Spanish speaker, trying to even just describe what had happened to you is going to be that much more difficult, right? And so we were able to have a doctor give the emergency room a heads up and say, hey, this person's coming in. These are the scans that she's going to need. These are the symptoms that she's experiencing. And so think about that, to be able to have such a traumatic event happen to you and to have a response so smooth that never happens, right? That never happens for our clients, but that's what we want for our clients. So that's really the goal of trying to raise as much awareness around this as possible. And for all the advocates that do ever encounter somebody that has been strangled, choked, this is a really good protocol to be able to be aware of. Any questions folks might have, you feel free to unmute yourself too if you'd like.
I have a question.
Yeah.
So my name's Michelle. I work here at News for Napa County. The LAP assessment, so I know that assessment is really for law enforcement to do like on the scene, but you said that your agency piloted a program and are doing LAP assessments as well. Are they using that same form?
Yes. Yeah. So there's a variety of different pilot projects that have happened over the number of years. But we partnered directly with Maryland Network. And we were 1 in 4 sites. And we were one of the only sites that decided that our advocates were also going to use that form. What I can say is the folks that we get on our crisis line, for example, who call in and we screen them in using that exact same form, screen it at 90% high risk, versus the folks who are seeing the law enforcement, and that's usually around 50 to 60%, sometimes a little bit more depending on the seasons ultimately and the calls that are coming in. But we use the exact same form. The only difference is we're doing a little bit more details, and also they're often more ready to enter into services because again, they're calling us for support versus the law enforcement. It's on the scene, they're overwhelmed, they just had the incident, we got 10 minutes with the law enforcement. So it is a little bit different in terms of how we work with the folks, but yes, it is the same 11 questions that we partner with the law enforcement. It's the same screening.
A follow-up question, if I may, would be, so the Jackie Campbell assessment, is there any particular reason why we were to not use that one versus the LAP assessment?
Ultimately for this particular program, it's because the Jackie Campbell is super in depth, right? And really, if you're not, a lot of agencies that I know of, and we were one that were kind of later trained into utilizing that. Our crisis line advocates can't do that, right? Like we just don't have the time. And really for that particular assessment, if you're not doing the calendar, the actual calendar, it is not the most accurate in terms of how much risk. It is super helpful if you're able to do in case management, but it also assesses different things. So it's a different kinds of risk. So it's not just high risk factors, but it's also life generated risks, right? Batter generated. It's a lot of other stuff that on the scene, the officers aren't able to do that. Now with California in general, all law enforcement jurisdictions are supposed to be trained on a lethality assessment protocol of some sort. There is a different lethality assessment tool that the Department of Justice uses. And so a lot of law enforcement jurisdictions who are actually not partnered with our agency use a longer tool. And that's probably closely related to the Jackie Campbell, but also has some really interesting questions that I'm not sure where they pulled up. So there is different kinds of forms, but really it's designed to be a quick, are you high risk or not? And those were the 11 questions that were present in all of the cases versus all of the questions on the Jackie Campbell, because Jackie Campbell herself was part of that initial research. So she herself was utilizing her tool with Maryland Network to review the domestic violence homicides. And so only 11 of those questions were present, and the weight of them is exactly why they're on the screening. So for example, one of them is, do you think you might be killed by them? That was about 90% of those who had been killed. And that was sometimes the only risk factor. That's why if that's a yes to that one particular question, it's an automatic high risk. The lethality assessment tool is also designed to overscreen folks. And so it's, have you ever right? Not within a certain time period necessarily. It's really designed for up to 12 months after you leave the relationship.
Mhm.
But it is a little bit more flexible in terms of the risk.
Thank you very much. It's been very helpful.
Any other questions from folks about strangulation protocols or questions about why some of the agencies are doing what they're doing? Yeah, Denise.
Hi, I work with predominantly children. I've had a parent once under domestic violence, strangulation, but I've had 2 children. Is there a particular assessment tool, and how is that used? Or, I mean, who fills that out, a parent or medical staff? How do we help a child get that intervention sometimes when parents are a little afraid of, the situation?
So our county doesn't have a specific tool for children and youth if they've been strangled. But, and Ashley, correct me if I'm wrong, I don't think our protocol would change. It's as soon as we understand that somebody's been strangled, the first thing we're going to do is think, do you need to go to the hospital? And that's where I think regardless of age, that's the first question that comes to my head as soon as somebody says I've been choked. So even if a parent comes in and says, their other parent strangled the son last night, we're not sure what to do, that's still going to be my first reaction. And honestly, I'd probably still give them the advisement card, because when you go to the hospital, you can just say, this is what I need. And it makes it a whole lot easier. And especially if that parent is really hesitant about admitting it to you, they're going to be less hesitant to admit what's really happening to doctors, right? Because they're professionals, they're scary. It's an overwhelming situation to be at the hospital to begin with. But Ashley, do you all have a different protocol that you utilize if it's like
No,
a child?
no, not that I'm aware of. I mean, I'd have to check into our children's counseling program, but I don't think that there's any particular tool. The only difference I think is the risk of brain damage is a lot higher because they're a lot smaller. And their brains are still developing, right? And so the risk of permanent damage is much more significant. So I would probably stress that a little bit more around the risk of that. Now, if it's an abusive relationship, right, and one parent is strangling the kids, it might also be happening to the other person and they either don't remember or something, right? Like there's something else that's going to be going on in that relationship. So there would be some other triggers and kind of a larger conversation in safety planning. But I think, again, really stressing the fact that because they're children and they are still developing, they're going to have they're at a higher risk of significant damage. And it takes a lot less for them to die from strangulation than an adult, because of how small their bodies are, all of that. And then also really increasing like the safety planning and of course, encouraging them to seek medical attention. It's and just validating the scare that if you are the parent who's reporting this about the other parent, CFS is going to be involved, and that's a good thing, bad thing. And there's resources who can support you in that process. And really it's around, keeping the child safe. Right. So just validating that it's entirely scary to talk to social services, because children do get taken, and the purpose and all of that, and how can we support you in that case plan?
Mm-hmm. Thank you.
Thanks, Denise.
Mm-hmm.
Other questions from folks? Okay, well, we're ending a little bit early, but feel free to reach out at any point to myself and Ashley. We'll have the recording up on the Family Justice Center's YouTube page. So if you just Google Contra Costa Family Justice Center on YouTube, it should pop up probably later on this afternoon. We'll also be sending out the slides and an evaluation for today's training. Please feel free to share the slides widely. We want as many people as possible to know about this information. But thank you so much for being here.
Thank you all.
Have a
Nice
good
to see you.
weekend. Bye, everybody. I was going to try and pull up music, and I don't think I have. I don't have anything prepped. That's okay. Thanks, Norma. feel bad that there were 2 links going out there. That was my fault.
Oh, well, it happens.
It happens.